Well, it is a great pleasure to have Dr. Klaus Fink with us today. And actually, we have been friends for at least maybe 15, 20 years, but I didn't know all his journey that he had MD, and then normally MDs are happy to practice, but he really started digging into the fields, whether it was in the Bonn University as initially being trained, and then later on at Harvard, he studied apoptosis of neurodegenerative diseases. I think it's looks like a very pre-designed journey of somebody coming from MD, which means he has the patient's interest in his mind, but he's really looking deeper from the other side, how the drugs are made and how they are used, how effective they might be, and then what is the process of that getting registered and then advanced in a business. And there he still holds on to his training of biotechnology and pharmacology. That is really an amazing thing. Klaus, when I meet with you, I like to hear your story about that because this is really a fantastic story. I love this kind of journey that people have, whether it was by design or by accident. And so he can share a very different kind of information because he, as a doctor, he feels for the patient, but then he also questions perhaps and then got some answers in his 150 papers that he has published. And he has shared that, and then he has been very humble, in my opinion. Whenever we have had these conversations of various kind, he has been very humble and very humane also. So I think it's wonderful to have you. And you can see Dr. Alok Dwivedi is a philosophy professor. He is a faculty of philosophy. His PhD is in philosophy. So he couldn't pronounce everything that you have written in your bio, and which is an Indian way of getting back to Germans who always pronounce things differently. So the one common thing is that Germany and India, they both have their linguistic system. They write the same thing as they pronounce it. So there is no learning out of it. So you could see that he was pronouncing like that. We have so much common historically, a lot more common scientifically. And so we look forward to your presentation today. Klaus,
okay.
Please begin.
Thank you, Baram, for the kind introduction and the nice invitation for this lecture. And let me just run a little bit because there's a lot to say of PK, pharmacokinetics of biologics. The biologics have been increasingly important in pharmacotherapy, mainly because they have that outstanding target specificity. They are what we call the magic bullet, at least capabilities. And on the other hand, biologics are a very diverse group of drugs. And I've listed you in blue here. They comprise the vaccines, blood components, gene therapy, somatic cells, tissue engineered medicines, and of course, protein therapeutics, which we are going to focus on today. But even protein therapeutics are a very diverse group of drugs. And I've listed here some examples underneath. Insulin's probably the most widespread used one, APO, growth hormones, enzymes, and monoclonal antibodies probably the most fastest proliferating group within the protein therapeutics here, and of course others in brackets is always molecular neurotoxicity, what we all are working on. Since the recombinant technology has become available in 1982, that was the time when the first recombinant human insulin became available. About 250 biologics have been approved by the FDA. But that doesn't mean that biologics started their life in 1982. And as I mentioned in the abstract, even back 100 years, 1890, Emil von Bering created or generated the diphtheria antitoxin in horses. And let me see whether that works. Yeah, and this photo is showing him bleeding one of these immunized horses, and that was made an antiserum available for the patients. And it was discontinued in 2000, yeah, in Germany, 2020 or 2018. And another drug which I also mentioned in the abstract was insulin. And that was identified in 1922 by Banting and McLeod in Toronto. And the year later, in 1923, it was made available commercially by Eli Lilly, and who extracted it from cattle and from pig pancreas islet cells. And that's how it looked like, and they called it, because it was extracted from islet cells, iletine. And this was actually extracted and made as a product until roughly 1990. So a long time, a successful drug. So biologics are not new. Nowadays, it's all about recombinant biologics. That's considered pretty new. Biologics are usually large protein molecules and are considered versus the small molecules. And that's, of course, a lingo. Peptides are even smaller than proteins, 30 to 40 amino acids, and have no higher order conformation structures as known for the proteins. And the largest pharma proteins, just for reference, are the antibody conjugates with more than 150 kilodalton in size. And this is just to demonstrate how important the biologics have become. This is the approval statistics of the FDA since 2000, and the yellow part of these bars is the biologics. And it has roughly always been 25% of the annual approvals by the FDA. Don't worry about the 23 bar here. The statistics was done after the first quarter of 23, so the other 3 quarters are still missing. So that doesn't mean breakdown. And in Europe, the EMA is doing even more biologic approvals. The statistics currently says 58% of the EMA approvals are biologics. So just to demonstrate how important that has become. In pharmacology, we used to say to the students, pharmacodynamics is what the drug does to the body, and pharmacokinetics is what the body does to the drug. And I think this fits quite well to the biologics as well. And let's see how this works specifically. In small molecules, we are usually considering the LADME. And LADME is LADMB, liberation, absorption, distribution, metabolism, and excretion, and which doesn't exactly fit for the biologics. But let's go through. Liberation usually means the liberation from the orally administered tablets. And that, of course, means some absorption in the GI tract, or it may even involve some hepatic first pass effect before it gets into the systemic circulation. And after that, there is always some distribution. Usually small molecules follow passive diffusion. And after that, the action of the small molecules is finalized or terminated by hepatic phase 1 and phase 2 metabolism. Very standard. And the excretion is either renally or biliary. And renal excretion, of course, requires some water solubility, and all the purpose of this hepatic phase 1 and phase 2 metabolism is to make these metabolites water soluble so that they can be excreted by the kidneys. So that's the pathway for the small molecules in biologics. There's not really an absorption. There's, of course, no liberation, but not even an absorption if the biologics are administered IV. And that's the majority of the biologics. After IV administration, the bioavailability is 100%. If the biologics are administered SC subcutaneously or intramuscularly, which also occurs once in a while, there is, of course, some absorption phase, and there is some loss. We usually calculate 50 to 80% bioavailability of a biologic that is administered into the subcutaneous compartment. Why is that? The reason is quite simple. From the subcutaneous compartment, it needs to go into the lymph drainage. And going there means it is exposed to the subcutaneous compartment with soluble proteases, which may cause the first degradation step. And then it is transported usually by transcytosis or convection into the lymph, but the lymph is running very slow. And first step will be it goes into the lymph nodes. In the lymph nodes, there are many immune cells which start to degrade whatever comes by. So these losses count up to, let's say, 40 to 50% or even more loss. So absorption from the subcutaneous space is a major loss in bioavailability for the biologics. Distribution is quite simple, as I just mentioned. Theoretically, there may be some passive diffusion. In the real world, it doesn't matter. But the major contribution is brought by convective transport and transcytosis. And metabolism is also quite simple. Usually it's catabolism in endocytic vesicles by degradation, or sometimes in the reticular endothelial system. And excretion, again, doesn't really exist because there is no renal excretion of the major proteins, because proteins can only be filtered in the kidney if they're smaller than 60 kilodalton. And the monoclonal antibodies, which I'm focusing here on, are 150 kilodalton, so they can not undergo glomerular filtration. And so more important for the excretion is the specific binding of the antibodies or anti-drug antibodies, or the neonatal Fc receptor binding for recycling mechanisms. All this plays a role, but finally the antibodies are degraded endocytically by lysosomal enzymes. So the routes of administration for biologics are quite simple. It's predominantly IV. Some are injected subcutaneously. You see the syringe is a little bit smaller, and very few are injected intramuscularly. And last week I've counted a list which I had at my hands, and 32 out of 46 monoclonal antibodies were supposed to be injected IV, 13 SC, and just one was supposed to be injected intramuscularly. And let's see. Here I've listed you examples for the potential admin ways of biologicals. You know, admin way is always the first step of PK. And of course, the option would be to administer the biologic orally, but that doesn't work because there are gastric enzymes which would degrade the peptide or the protein. There will be a very poor intestinal resorption. So this is not a feasible option, and I haven't found a single product, and has never existed one. In the following 3 lines here, this is the injectors or the parenteral administration ways. Number 1 is IV, of course, the most important one. And if you want to keep in mind one example, I would suggest go for the old filgrastim. That's one of the colony stimulating factors, and which still exists and is still administered IV. Bioavailability would be 100%. The following line is subcutaneous administration, injection. If you want to keep one in mind, I would go for adalimumab under the name Humira, which is probably the best-selling drug which ever existed. And I mean, in terms of revenue. And the subcutaneous injection, you might think, why is it not injected IV? Can be explained because the company wanted to prolong to extend the duration of action. First, of course, the onset of action will be longer after subcutaneous administration due, what I said, the slow transport into the lymph and slow transport with the lymph. Just keep in mind, lymph is transported just 15 milliliter per day if you're not running marathon, of course. And that means everything is going very slow if it finally goes into the circulation. Circulation with the blood is very fast, but lymph is very slow. That takes time. In other words, if you inject adalimumab into the subcutaneous compartment, it will take 6 to 8 days to appear in the circulation and reach the final levels. And then the duration of action extends to about 1 month or even longer. And the third one would be the intramuscular injection. And I haven't found antibody, which is injected, but I put here the botulinum neurotoxin. So you may know that under the label name Botox. That has a very complicated pharmacokinetics and needs to be injected right into the compartment of interest. So if there's time at the end of the talk, I can allude to this a little bit more in detail. The following line is after the pulmonary application. And pulmonary is an option for smaller proteins such as insulin with 5.8 kilodalton. Pfizer launched a product under the name Exubera in 2006, offering ease of use and rapid onset of effect, which was the case. But the PK was difficult and it was not accepted by the patients because ex-smokers were found to exhibit a higher risk of lung cancer when treated with the drug. And it was finally discontinued after 1 year. The other product, which I put here, Dornase, that's a DNase, and that's inhaled by patients with cystic fibrosis, where it cleaves the DNA of cells in the mucus and by that reduces the viscosity. So that's actually a more topical administration and it's not what we understand under pulmonary administration and resorption. The following line is nasal. And the intranasally administered biologics are smaller peptides, and the admin way is well established. Calcitonin has 3.5 kilodalton in size. IGF-1 has 7.6 kilodalton, and oxytocin has 1 kilodalton. So the intranasal application and resorption works well under 2 kilodalton. And between 2 and 6 kilodalton, it needs a resorption enhancer. Drugs like propylene glycol or the aminocapryllic acid, these things. And that helps to get a little bit larger proteins over the epithelial barrier. Next line is oromucosal. And oromucosal administration and absorption way is not very well suited for protein drug delivery due to the enzymes present in the mouth, and again, the molecular size being the ultimate obstacle. Using absorption enhancer make it possible, but should not expect 100% bioavailability. The bioavailability after oromucosal administration is in the 2% range. After nasal administration, in the 2 to 6% range, so not more. And the next line, so there is a product on the market, and it seems to be, apparently it's on the market in India, which I didn't know until I looked it up for this presentation. It's an insulin which is administered through oral mucosa. So in Western countries, this doesn't exist. The transdermal application doesn't work per se, but it can be made possible with help. Help means ionto or sonophoresis. And insulin, interferon gamma, EPO alpha have been successfully delivered via sonophoresis, and leuprorelide, insulin, the growth hormones, calcitonin, I think PTH have been administered successfully by iontophoresis. And the last line is topical administration, and which I also didn't know before. there's one product, Regranix, and Regranix is a recombinant platelet-derived growth factor for topical treatment of diabetic skin ulceration, and is not supposed to permeate the intact skin and end up in the blood. It acts where it is administered, so it's not resorbed. So just to give you an overview what is possible and what's not possible with biologics. And going into the basic PK now. And distribution of, let's stick with the monoclonal antibodies as an example, follows three mechanisms. The first one is passive diffusion. It doesn't play a significant role in monoclonal antibody extravasation. So I assume the monoclonal antibody is injected IV and wants to make its way over to the lymphatic system and back into the circulation. That's what should be done. Number two, the second mechanism that exists is convective transport. And the main mechanism by which monoclonal antibodies are distributed from blood into the tissue is driven by first the blood tissue hydrostatic gradient and the sieving effect by the paracellular pores in the vascular epithelium or endothelium, depending on size, tortuosity, and number of the pores, plus of course the shape and shape of the antibody. The principle behind convection is the differential between hydrostatic and oncotic pressure and the sieving effect of the endothelium. Yeah. The third mechanism, which I've listed here, is transcytosis, also very important. And one of them is always the dominant one. And transcytosis through the vascular endothelium may be mediated via the neonatal Fc receptor, the famous FcRn, the Bram-Bell receptor. There are many names for it, especially in tissues where convection is limited. Transcytosis may be directed in either direction, so from the blood to the interstitial space or from the interstitial space into the blood, and same on the lymphatic vessels as well. And distributive monoclonal antibody removal from the interstitial space depends on convection into the lymph, which is dependent on the same parameter as the convection on the other side from the blood into the interstitial compartment. As a result of the good convection into the lymph, the amount of unbound monoclonal antibodies in the interstitial tissue space is usually very low. And this is a very typical PK cartoon and taken from the textbook of small molecules. And it shows a simple two-compartment model. And the first compartment is the pink one. It should be the vascular compartment, usually called the central compartment. And the green one is the extravascular interstitial space compartment, usually called the peripheral compartment. And this works for most small molecules, and it's not too bad for many biologics. And what they said in this textbook is that wondering about a drug A, B, and C, and drug A was equilibrating between the two compartments easily. So it could migrate between compartment 1 and B easily. And so the volume of distribution finally is basically the addition of the vascular compartment, the extracellular space. They say 10 liters. But drug B is different. It doesn't go into the peripheral compartment because it is stuck in the vascular compartment. In the vascular compartment, usually the small molecules bind to albumin. And this is very rare for biologics, but this is where the drawing comes from. So I wouldn't think this is very important for biologics. The third one is stuck in the peripheral compartment, and there's not much of the drug found in the blood. And this may be the case for biologics, and we can assume, of course, this is different, what the image says, but it could be assumed that this is the target binding of monoclonal antibodies in the periphery. So that would fit somehow. So taken together, I've copied you here a list of distribution volumes of small molecules. And what we tell the students usually is that one of the worst drugs is chloroquine, which has a volume of distribution of 13,000 liters. And another example for a huge distribution volume would be the antipsychotics. The only one I see here is nortriptyline. They are in the range of 1,000 liters. Very, very lipophilic drugs. And if you go down, there are tolbutamide, and so these small molecules, but the biologicals would be right here at the bottom of the scale, right here in the range 3 to 10 or 3 to 15 liters, not more. So the volume of distribution of the monoclonal antibodies and most biologics is very, very limited, mainly because of the huge size, the molecular weight, and the difficulty to get it somewhere into another compartment. This is a busy slide, and the illustration contains on the right side the construct of an antibody, of an IgG antibody. On the left side, an example for penocytosis and the neonatal Fc receptor mediated recycling process. So let's start with the structure of the antibody. The IgGs, as you may know, consists of heavy chains and light chains. So this one here is the heavy chain, and the accompanying part is the light chain. Same on the other side. So the light chain is 25 kilodalton, the heavy chain is 50 kilodalton, and that doubles. So in sum, this ends up at 150 kilodalton of an IgG. And it has 3 binding areas. The FAB binding areas up here are those ones for specific target binding. And FAB means fragment antigen binding. And it consists of 3 hypervariable regions in these terminals of the Y ends. And sometimes these are called CDRs, which is what's it called? Complementarity determining regions. Same thing. So number 1, number 2, and the third binding site is the Fc binding site. That's actually here. And Fc binding site binds to the Fc receptors. Fc receptors are found on almost any immune cell. So macrophages, lymphocytes, CDs, disease dendritic cells, whatever, they all have Fc receptors where this antibody binds, and it may also bind to C1q from complement and triggers an immune reaction. Of course, the immune reaction will finally eliminate the antibody which is attached to it as well. And just to illustrate this, this is the CDC pathway. So if the Fc receptor binds to C1q, the complement, so this is the antibody here, and it binds to with Fc to the complement, and that triggers activation of the complement. The complement will introduce into the membrane this huge channel, and the complement complex, which just opens up the channel, tears it apart, and the cell will die. And the second option would be that the Fc binds to a cell. So CDC means complement determining cytotoxicity, and ADCC means antigen-dependent cell cytotoxicity. And so that's here, the Fc binding to an immune cell, and the immune cell will either phagocytose the whole thing or will release, let's say, interleukins to destroy everything what here is, including the attached antibody. So that's the way these antibodies work, and actually it also sheds light on how these antibodies are eliminated. And one of those ways which can go either way is the endocytosis way. And the antibodies can be endocytosed via a receptor. This is one of the FC receptors, and it's the FcRn, which means neonatal FC receptor. Initially, this is called neonatal because it in lactating mothers, this is used to transfer antibodies into the newborn, to transfer the antibody, because the newborns don't have a sufficient immune system. And that is used in our immune system for recycling of IgGs, which means the antibody doesn't matter whether endogenous IgG or monoclonal antibody introduced as a drug will bind with its Fc part to the neonatal Fc receptor and goes into an endocytic vesicle. The endocytic vesicle, of course, will be acidified as always, and upon acidification, it will separate into a release in the recycling endosome and lysosome. So in the lysosome, everything which resides there is degraded, and in the recycling endosome, everything goes back to the surface and will be released again. This is very important. If this wouldn't exist, we would have to produce 3 times the amount of IgG that or endogenous IgG, because otherwise we would, without any sense, just degrade it every day. And those are the monoclonal antibodies which have been developed over time, starting, let's say, 1990. And the green thing means murine antibody, murine protein sequences, and the red is human protein sequences. The murine still do exist, and an example for that is the ibritumumab, coupled to yttrium-90, and so radioactively labeled. And that's an antibody against CD20. So the problem with this antibody is that it has an unacceptable high rate of immunogenicity, of inducing the formation of anti-drug antibodies, ADAs. So the rate is more than 50% of the treated patients. And that's the reason why these antibodies, the majority of these antibodies have been discontinued. And the first next step in development were the chimerics. And chimerics mean the backbone of the antibody is taken from a human IgG, and just the VH and VL, the green regions, are taken from mouse antibodies. So that needs, of course, to be recombinant and to be engineered. And so there was an improvement. And the next step were the humanized antibodies. And humanized means it's a human antibody construct, but the hyper variable regions, the CDRs here, the green stripes, are taken from mouse due to the engineering. And I would say gold standard nowadays is the human antibody, which doesn't contain any mouse sequence, protein sequence at all. But that doesn't mean that those antibodies do not induce the formation of ADAs, anti-drug antibodies. So they are a foreign protein with a certain capability of inducing immunogenicity. And that's the blue triangle here. It's not going to zero. That were a short walk through the PK of the monoclonal antibodies. Now I'm going through some factors either by the drug or by the patient. And the product-specific factor is glycosylation. And as you see here is an IgG in another drawing, and IgGs are glycosylated. And the point of glycosylation is, one of the points of glycosylation is the ASN297. And that's very close here to the Fc receptor. And the type of glycosylation at this point determines on the affinity of binding to the Fc receptor. And just to give you, you see that there are many, many options for glycosylation here. But just to give you an idea what it means, an example, if the ASN297 is not fucosylated, so the red triangle is not carrying fucose in the glycosylation chain, it strongly increases binding to the Fc gamma receptor, to which the Fc in this case would bind, enhances the ADCC, so the antigen-dependent cell cytotoxicity on the tumor cell to which it is directed, which means the tumor toxicity of this antibody is strongly increased by removal of the fucose. But on the other hand, the strong binding of the antibody to its target, so the target would be, let's assume trastuzumab, is Herceptin, they're used for breast cancer therapy. So the strong binding to the target means that it is eliminated with the target cell. So the success on the one hand means shorter half-life on the other hand. And what has been shown in trastuzumab is that the half-life was decreased by afucosylation from 13 days to 10 days. Interesting, the first trastuzumab product on the market had 8 different glycosylations within one product, and they all need to be characterized. And I'm just saying that because biosimilars are sometimes very diverse, and they don't have to mimic the exact glycosylation pattern of the originator, but it needs to be characterized. And that's a hell of work, and you have to demonstrate that it has the same PK and the same PD as the original. So this, I think we can skip. Of course, there are always options for chemical modifications and degradations of certain amino acids. Basically, let's stick with the upper table first. A small molecule can undergo aggregation, precipitation, and absorption, as well as the large proteins, but only the proteins can undergo denaturation. That's something which adds on, and that denaturation depends on heat, cold, or agitation. But as we're not having examples here, we don't go into details. A patient-specific factor that I wanted to bring to your attention is ectodomain shedding. And you may not have heard of that, but one famous example of ectodomain shedding is CD52 shedding in CLL patients. CLL is chronic lymphatic leukemia. And the antibody targeting CD52, which is used for therapeutic purposes, alemtuzumab. But this is, as all CDs, is a membrane protein, a surface marker, and it breaks apart or is cleaved, and that is called the ectodomain. So the outside part of that protein is going into the circulation when it's cleaved off the total protein, which means the patient with CLL as having in his blood a lot of CD52 ectodomains, not the complete CD52, but that binding position, which is usually exposed on the cell surface. And if one injects or infuses alemtuzumab for treatment in this patient into the circulation, it will, of course, meet these CD52 ectodomains, and they will bind. And these immune complexes will be circulating and will be removed by the immune system. So a lot of the monoclonal antibodies, alemtuzumab, which we inject, are just wasted because they bind these circulating but useless ectodomains and will not make it to the intended target, which is a CD52 that is still on the cell surface and hooked up to its pathway. So that's a problem here. I'm asking, what does that mean for PK? The immune complexes of monoclonal antibody and circulating ectodomains are engulfed and degraded, and it reduces half-life. Of course, it also reduces the effect, but that's PD. And the next patient-specific factor which affects PK is the inflammatory status. As you may know, cancer and autoimmune diseases as well cause chronic inflammatory responses. And very prominent in cancer patients in the final stages is the loss of body weight, which we call the cancer cachexia. And 50% or more of the body protein turnover is increased, and which is the basis of the loss of protein and muscle protein in these patients. So what does that mean for PK? The strong inflammatory response causes an increase in non-specific catalytic clearance of the IgGs, I mean endogenous and exogenous IgGs, and HSA, human serum albumin. That means shorter monoclonal antibody half-life, less effect will of course be pharmacodynamics, and it always depends on the inflammatory disease state. And why? And as a result of this, we usually check CRP, C-reactive protein, in these patients, which is an indicator of the inflammatory response, of the inflammation which is ongoing. And the CRP level is predictive for the monoclonal antibody clearance. So the higher CRP, the shorter the half-life of administered monoclonal antibodies, because of the turnover which increases with inflammation. And I've put some examples underneath. The trastuzumab is a very famous example in breast cancer, and infliximab in rheumatoid arthritis patients. And we've now talked a lot about monoclonal antibodies because I think it's the most fascinating protein therapeutic. But of course, there are smaller ones. And the smaller ones, at least if they are smaller than 60 kilodalton, can be glomerular filtered in the kidney. And there are three mechanisms by which they can be eliminated by glomerular filtration. And number one is this one. It's filtered by glomerular filtration in the primary urine. The primary urine is taken up into the tubular cell. Within the tubular cell, in endocytic vesicles, it's degraded by lysosomal enzymes. Very standard. And the second one is it's filtered into the primary urine, but it is degraded in the brush border membrane of the tubular cell. And the third mechanism by which these smaller proteins can be removed from the blood is the uptake from the blood from the postglomerular capillary into the proximal tubular cell, and degradation in the tubular cell again by endocytic vesicles. So anything is possible, and the first and the second require glomerular filtration, the third one doesn't. But at the end, there's no protein, there's no parent protein in the urine, if nothing else happens. And last thing, depending on the patient, is the ADA formation. And I haven't talked too much about the ADA formation now, but just keep in mind, ADA, anti-drug antibodies, can be neutralizing or non-neutralizing. If they are non-neutralizing, they won't affect the effect of the monoclonal antibody, but the half-life. And half-life will become shorter. If they are neutralizing, they will affect the effect of the neutralizing antibody, plus the half-life. So irrespective of neutralizing or non-neutralizing, these antibodies will always reduce the half-life of the product. And neutralizing antibodies can be detected. Non-neutralizing antibodies difficult. But you see them if the half-life decreases overly, it's always an indication of a non-neutralizing antibody. And what this shows here, the cartoon shows, is the several options for elimination. They call it clearance pathway. And number one is administration of the monoclonal antibody into the circulation, so into the blood. That's the central compartment. In the blood, of course, there are soluble proteases, which may degrade a little bit of the injected monoclonal antibody. That's the clearance pathway number one. And from the blood, there will be extravasation by convection or transcytosis into the interstitial space. In the interstitial space around the vessel, there again soluble proteases or transport into the reticular endothelial system, where the protein, the monoclonal antibody in this case, will be degraded. That's called clearance pathway number two. And if the antibody in the target zone binds to its target receptor, R is the receptor here, which of course is in a steady state. But if the antibody binds to the receptor, they will form a complex. The complex will finally, if it's a circulating complex at least, be detected by the immune system. Immune cells will engulf this complex and will remove the antibody attached to its target. So just keep in mind the target could be TNF-alpha. And the antibody, like adalimumab, binds to TNF-alpha, and the whole thing circuits as an immunocomplex will be engulfed and removed. The whole story is the monoclonal antibody that we have administered is gone. So it shortens half-life. It's a clearance pathway for the monoclonal antibody. So that's pathway number three. And this is what we call TMDD, target-mediated drug disposal. Target, that would be the TNF-alpha, the receptor, target-mediated drug disposal. So that it goes because it's done its work. And the fourth pathway is if anti-drug antibodies are available, if the body has produced them. And of course, they are in a steady state, but if the binding occurs, the binding of those antibodies do exactly what's happening here. They form an immunocomplex of the anti-drug antibody with the monoclonal antibody, the therapeutic antibody. And those immunocomplexes are just detected by macrophages are eaten up and removed from the circulation. That's called clearance pathway 4. And that's the AD antibody effect on PK. So very briefly, what this means in the curve, I'm not showing much curves here, but what this means is that the concentration of the infused monoclonal antibody is reduced to all these removal pathways. The concentration used, and on the other hand, the duration of action becomes shorter by those antibodies. And it doesn't matter whether the antibody binds with the FAB or with the FC part. So anyway, will work. This I'm not going into detail. And this is the following slide. If you want to model PK in therapeutic proteins, you could do it the simple way and use a two-compartment model with first-order elimination kinetics. First-order elimination kinetics is usually linear. Linear if you do it half log. So there needs to be a log y-axis. If you don't do that, do a linear y-axis, it will be an exponential decay. But this is the standard graph of first-order kinetics. That works very nicely in two-compartment models for small molecules, and it does for some proteins, but not for all proteins. Usually, specifically, the monoclonal antibodies require a little bit more attention. And one option is to use a TMDD model, so target-mediated drug disposal model. And I just want to draw your attention to the green curve here. As you see here, there's a very, very tiny and fast drop. And that's the distribution phase of the antibody. The antibody is infused and finds its target and bang, binds to the target and does what it's supposed to do. After that, there's a very extended phase, a linear phase, flat, of antibody target saturation. And after that, the antibody is at least largely removed, and it will no longer be able to saturate the target. And that's the point where the degradation of the antibody gets very rapid. And phase 4 is irrelevant here. So, but I just wanted to draw your attention to the green curve here. That's what we call in PK a hockey stick curve. And so the first one doesn't count, but this long, this is the grip, and this is the bottom of the hockey stick. And this occurs again and again, a linear elimination followed by a non-linear elimination when the concentration of the monoclonal antibody is lower, getting lower. This can be modeled in a number of models, and software is around for this. What the FDA is requesting is a PBPK model. That means a physiologic based pharmacokinetic model. And that's even more complicated because it needs to consider up to, I think, 16 compartments in the body. That's what I put the body on the right side, and it numbers the compartments which are considered here. And in each compartment, it calculates the influx and the degradation and the elimination and gives its contribution to the serum concentration of the drug of interest. So it's quite a lot of data that you have to put in, and quite a lot of calculation that goes on in this. But it really considers everything. TMDD is considered, convective extravasation, the recycling via the neonatal FC receptor is considered, of course, proteolytic degradation is considered. So that's a very comprehensive way to model pharmacokinetics. So if you need software, there is a lot of software around. I put here some, and the one I'm using is not in the list because it doesn't cost anything. It's from a local university, and that would always be my first suggestion. Check what the local universities are offering. It's not the worst. And but among the commercial offerings for PBPK, when accepted by the FDA, the Cybertext software would be an option. What's also quite nice, but not PBPK, but also working quite well, is the GastroPlus software, which I think we have in the company, and that's an ACAD model. ACAD is the advanced compartmental and transit model, and they have a biologics add-on. That's the point. Yeah, there is an add-on into the software for biologics to make it suitable for these purposes. So just to give you an idea how this is modeled. And if you will, I have prepared 2 more slides for our famous molecule, the botulinum neurotoxin, which has a very, very difficult PK. And usually by nature, botulinum neurotoxin is made a food poison. And that means if it's eaten, it goes into the gastrointestinal tract, which is first compartment. In the gastrointestinal tract, of course, the proteins are destructed. In this case, there are protective hemagglutinins, but that's not important here. It will finally be absorbed from the GI tract into the blood. That's compartment number 2. And from the blood, it goes into the interstitial space of the skeletal muscles. And that's compartment number 3. And within the interstitial space of the skeletal muscles, it goes into these neuromuscular junctions, and it goes in here in the synaptic cleft and is taken up with the release vesicles. And once it is in one of these release vesicles, it's in compartment number 4. And then the molecule is divided up, and it is an AB toxin, and the light chain of the AB toxin is then released into the cytosol here. And that's finally compartment number 5. So it's a 5-compartment PK, and the molecule separates in compartment number 4. Very difficult to model. And for therapy, of course, eating or food poisoning doesn't play a role. The molecule is injected as far as possible in front of or into the compartment of interest. That's the muscle. So the neurologist even try to inject in front of the neuromuscular junctions, which are not all over the muscle. And so that means compartment number 1 is the holotoxin goes in the interstitial space between the myofibrils of the muscle. Then it is taken up from the synaptic cleft, as I said. This is a nice drawing from the Piracini review. And this is the binding domain, and the yellow thing is the translocation domain. And the red Pac-Man here, that's the light chain with its catalytic activity. So the light chain is released into the cytosol and goes into the 3rd compartment. And as you see, duration in the muscle is minutes to hours. Duration in the vesicle is in the minute range. 5 or 12 minutes have been measured here. And once it is in the cytosol, the duration of action is 110 days in human. That depends on the species. And the activity, the catalytic activity of the light chain, which cleaves the proteins of the snare complex, determines the biological effect. So just keep in mind, you can measure every compartment ahead of the biologically important compartment of interest, the cytosol, the neuronal cytosol, but it has no meaning. And the only meaning is the last compartment, the concentration in the cytosol. And the decay, the degradation of the cytosol is linear over 110 days, very slowly, according to escape from the proteasomal degradation, probably due to deubiquitination. And so just don't look at the image on the left side, but on the graph on the right side. And that shows, again, a very steep initial curve. And that's the distribution phase, which I showed you on one of the previous curves. And after the distribution phase, the very shallow and linear degradation phase starts. In humans, this is very long. No one measures that because the assays are not sensitive enough. But if you can bring up the concentration to a level where it can be detected, you would see that the curve goes on and the neurotoxin is still there after 25 days and even beyond in the circulation. But that doesn't mean anything in terms of biological effect, because that doesn't reflect the light chain concentration within the presynaptic terminal cytosol, and that cannot be measured just by its effect, of course. So that's a note of caution for modeling PK in big molecules in proteins. I guess we are pretty through with our time. I made some slides on biosimilars, but I guess we can skip them. And how is our time? Well, I can't hear you.
Got another 5 minutes or so. You can take another 5 minutes.
Okay, if that's okay with you.
Yeah.
The I've made this 2 slides on the biosimilars, because biosimilars are in everybody's interest, because the biologics, specifically the monoclonal antibodies, are so expensive. And the point is the Europeans are rather have a long-standing tradition of the biosimilar approvals. I think they started early in 2005 or so, I don't know. And many approvals are here in 2006, and we have currently 79 EMA-approved biosimilars. The FDA started much later in 2015. There was the Obama Act in 2010, but that didn't have any consequences, so they have approved 45 currently. And the initial approvals were pegfilgrastim, so the old guys in the field, and infliximab, etanercept, and adalimumab in 2016. What the FDA requires if one wants to have a biosimilar approved is an extensive non-clinical analysis of the similarity in vitro and in vivo. So that's a lot of work, but it requires only that you have the originator at hand, or the data at least, where you can compare the new drug with. And then there will be a phase 1. And everybody, many people look at this phase 1 study like PD bioequivalence. But more importantly, it's PK, bioequivalence, safety, and immunogenicity, what the FDA is looking for. And PK is exactly what we have to present in the small molecule generics. If we make a generic drug and is approved, we just need to present the bioequivalence. So the one bioequivalence study with a new drug. But PK is very difficult to demonstrate sometimes for the monoclonal antibodies in humans. And immunogenicity has to be shown, which means clinical immunogenicity. You have to demonstrate these antibodies in humans. You have to generate an assay to be able to determine these antibodies. And after that, you can do, or you have to demonstrate that the clinical outcome is not different. And from that point, you can extrapolate the one or the other indication, which is the real benefit of a biosimilar. But I'm just saying that because PK and immunogenicity, and of course non-clinical similarity, are usually considered as negligible. It is not. This is very important if you want to get it improved according to 351K. In India, I know it's different. You don't have to present this data to get it approved, but this is and it's not, in Europe it's also different, but this is the FDA way to go. And just to explain why immunogenicity is so important for the FDA, in EPO, one of the early approvals, many ADAs were generated by the patient, so anti-drug antibodies. And those antibodies, of course, don't inactivate the injected EPO, but also the endogenous EPO, which means the patient didn't have any EPO left. And those patients ran into the so-called PRCA, that's the pure red cell aplasia. They had the blood was quite normal without any red blood cells, no erythrocytes, so pure anemia. And that can hardly be treated without transfusion because whatever you do, any EPO which you inject in the patient will be taken away by the antibodies that the body generated. The ADAs, which were generated against the drug, will then work against endogenous EPO and exogenous EPO. And this is a disaster in those patients. So immunogenicity is very important. And this, again, the EPO story. These are 8 products which are on the market in different countries. And what I want to demonstrate is they all have different glycosylation patterns. So the biosimilar doesn't have to be exactly the same as the original, but it needs to have the same PK, the same PD, and that needs to be shown. And this, these glycosylation patterns is a lot of work to compare. So I think we leave it with that. And thank you very much for your attention.
Thank you so much. It has been very informative to even me, which I thought I know a little bit about some of these things, because you went into the very basic origin of some of these terms and needs. I thought, I didn't know the biosimilar you have to do clinical trial 3. So I thought biosimilar means you just need to show something about some, maybe label 2, clinical label 2 or something. So that's great. I have a couple of questions, and then I'm sure some other people may have questions.
Go ahead.
So one of my question is, from your experience, because you have the both sides, the how the drug is used and how it affects, and also how this is produced and what may be the mechanism. At least some of them we talked about translocation. Do you think that in the translocation process also there is some biological signal transduction, not necessarily just related to translocation, but something else it tells to the cell? So as an example, would botulinum toxin translocation versus same size 150 kilodalton antibody translocation would have the same otherwise physiology, whether you're talking about the lymph or blood or some neuro signaling? Would that be the same, or do you think there may be something, these molecules send some other messages also to the cell to prepare itself?
They do. This is the question of someone who knows a lot, because everybody is talking about what we call canonical effects of the neurotoxin, but that's not the whole story. And we did together that story 10 years ago or so, when we did the transcriptome analysis of some cells in vitro.
Yeah.
And we were wondering, there was always an upregulation and downregulation of transcript by the neurotoxin and as well by the complexing proteins. And we didn't know what it means. And it may not mean anything in terms of physiology, but there's more than just the physiological or the canonical inhibition of acetylcholine or other neurotransmitter release. There's more, and it's just about to be studied. And we are also studying, of course, you know that, we're looking into neuropathic pain, and it's very questionable whether the canonical mode of action is the central mode of action in these pain indications. So that, yeah, the question is very wise, and I don't have the good answer or the comprehensive answer to it.
One more question, and then I will let other people ask questions. You also mentioned the very interesting thing that individuals have differences, and you gave example of CD52. So how much difference? I mean, obviously, when we do clinical trial or anything, even animal studies, we take some kind of statistics and we say, well, some variation is acceptable because somehow that is be convinced. I was reading yesterday somebody's post that there was a time when there was a prohibition all over the world, then doctors were allowed to write prescription for alcohol. So I guess anything can be done in the name of health and doctors, whatever the professionals are. So I guess the dose already defined and prescriptions made. But how much difference you think that has? Is that something significant people should worry about?
Yeah, well, this was tumor therapy, which I was talking about, the CD52, and yeah. Actually, before treating a tumor with one of these antibodies, monoclonal antibodies, one needs to check the genome and transcriptome of this tumor. Otherwise, you wouldn't know whether you shoot into the blue. And so that would disclose the differences between the patients. But there are patients which would not respond at all and others who would respond. And that is not yes or no, but it's a large field in which it differs. Some of them produce the shedded epitopes and others don't. So, and this would not be included by the transcriptome or the genome analysis of the tumor. So there's much more to it. It's very difficult to predict the response to these monoclonal antibodies.
Thank you. I'll let other people ask question. I have another one, but I'll come back. Anybody else has any question? It's in there in the chat box, Klaus, if you want to read it.
It's in the chat because I couldn't understand the
Yeah.
Where is that? The chat box. I see. Yeah.
Chat box. Yeah. Can you see it, or you want me to read it?
Here I am. You what the availability of in the circulation was. Yeah, thanks for the question. This is a very standard case. Because albumin gets lost in cancer patients and it requires adaptation of the dose. So if in case the clearance is increased by, let's say by increased removal of albumin, the dose is increased. So the administration interval needs to be shortened, and the higher dose or shorter intervals will be administered of the drug. And if the clearance is slow, yeah, it could happen in patients with impaired renal function. If that is, I don't think it can be predicted for many drugs, but if it turns out to be the case, of course, the interval will be prolonged and the dose will be reduced. But that's pretty rare. The first case that you are asking here is very common, and the second one is pretty rare. Yeah, but it's always adaptation of the dose or shortening the interval. And in oncology, no one cares about immunology. I mean, in terms of ADA.
Okay, great. Anybody else has any question? So, oh, there is one more message. I just need to see whether just Rajkumar says thanks. Okay. I have while somebody else may be thinking about a question, I have two other questions. One is continuing with that discussion about differences and your background in psychiatry. Does that make any difference of a state of mind of people?
What do you mean?
I mean, somebody may be very nervous. Somebody is like, is very much concerned, or something like that. Does that, obviously we know that makes the physiological differences in body. Stress causes a stress, and those things also may be having more effect on this clearance or binding and things like that.
Yeah, I'm convinced they make a big difference, but there's no evidence for it. So there are no clinical trials which have proven the effect of stress on PK of specific drugs. But I'm convinced the effect is there. And so let's assume that that steroids are exploding under this under the stress. And of course, they have multiple effects, and of course, they must interfere with the degradation of the PK of the monoclonal antibody used for treatment of the cancer. But the evidence is very low for that.
Is because nobody checks this out, or is this something? Yeah. So
no,
they don't want to get into that. They just don't want to get into that.
I guess
okay,
it's
the last
new.
last question. You said that Bonn had life in the circulation. It's like 25 days or something that you said.
Yeah.
Is that same as other proteins, or is this something that very peculiar?
No, it's basically the same as in other proteins. If you compare it to IgG as a similar endogenous protein, the lifespan of IgG is I think 21 days or so.
Oh, okay. So there's nothing there.
No, it's nothing specific for the neurotoxin. It'll stay there for the same time because it'll be. I'm not sure whether it'll be FC receptor recycled. I don't see why that should be happening, but it's not degraded instantaneously in the blood or in the tissue. And I'm just hammering on this point because my own company is telling these stories, which they have not the slightest idea about PK of the drug they are selling. I mean, the PK of botulinum neurotoxin may be complicated, but it's not extraordinary. For each compartment, it's very standard. It's just the addition of the 5 compartments or the 3 compartments, which are going in parallel, is very difficult to model, but the PK itself is very standard.
Okay, well, thank you. If there is no other question, unless somebody shouts at me, you have another question. Okay, so no, he can read. He can read. I think because the voice is not coming that clear. Klaus, can you read that?
Yeah, I want to ask what could be possibility of changing the biologics, such as formulation or increase glucose binding or at therapeutic molecule level. What could be the options? Yeah, any option is open for. You can modify a monoclonal antibody as you like, and that is already done in pharmaceutical industry. A new antibody currently, it's all about migraine CGRP antibodies. They are modified in any way you can think of, and either increase the affinity of binding, which has its back side, which means shorter duration of action, or the other way around. And so you were talking here about FC receptor modification, which you can of course do, but the developer of a new antibody is more interested in the FAB, so the specific binding of the antibody. And there's a lot of engineering going on at the FAB, the complementarity determining regions of the antibody, and to increase that interaction with the specific target. And yeah, the field is open. You can do whatever you like. And if the question is if you want to modify a biosimilar and compare it to the biological, I would be very careful because or cautious, because in the end you need to prove the similarity, and I would change as few as possible.
All right, every good thing comes to end. So this too. So I mean, be very grateful to you, Klaus, not only for making a beautiful presentation, but beginning in such a way that I'm not sure if Rajkumar had explained to you, this institute is a mixture of philosophy and science. And so you brought in such a way that I think it made sense to philosophical people of that tenor. So they can see where you are coming. And, our purpose here is to try to integrate because ultimately, you showed models, for example. I mean, those models are communications. Obviously, that's the way we communicate to each other, as well as to maybe just sometimes general people also. And that kind of communication is very important for us to see the philosophical aspects, and particularly, a lot of philosophical aspects came out of Germany, believe it or not, and of course India. So there is that commonality also. Maybe that will enrich our science as well. Like, I just talked to you about the state of mind is more like a philosophy. I happen to be able to teach a course in UMass called Chemistry of the Mind. So I also have some interest from that point of view also. So this is wonderful. Really, we enjoyed it very much. Thank you so much. And we hope that we will be able to invite you some other time again on some of these topics. Thank you so much again.
Very nice. Thank you for the invitation. Okay.
Somebody will call it off. I think Rajkumar is still the host. And I'll connect with you.